Today's program has been designed by our OLLI at UNC Asheville Inclusion Committee. In the wake of the COVID-19 pandemic, the historic and current inequities created by systemic racism have been illuminated. The disproportionate impact on communities of color are strikingly visible in the areas of healthcare, criminal justice, education, and economics, and we will address each of those areas in the series. Each session in the series will include presentations and conversations by local leaders, professionals, and Asheville Buncombe community members in their respective roles engaged in addressing these issues. The presentation of the series is an effort to raise awareness and to inspire personal engagement and advocacy. Many thanks to Wallace Bohannon, Jane Callis, Bill Carpenter, Larry Haas, Sam Harbin, Annie Houle, Morgan Jackson, Sarah Reinke, and Dan Azar, the members of OLLI's Inclusion Committee, for their thoughtful work in putting the series together. I also want to thank OLLI Facilities and Communications Coordinator Jacqueline Lowe for her work teaching us about webinars and organizing the publicity for this series. And now it is my pleasure to introduce our speakers for today for a presentation they have titled Including the Invisible: Race, Place, and Faith in Rural Western North Carolina. Our panel includes Dr. Ameena Batada, Associate Professor of Health and Wellness at UNC Asheville, Joanna Grier-McEachin, Executive Director of the Asheville Buncombe Institute of Parity Achievement, ABIPA, and Jill Fromewick, Social Epidemiologist and Research Scientist at the Mountain Area Health Education Center, MAHEC. Working together, they have earned a 3-year, $350,000 Interdisciplinary Research Leaders Fellowship from the Robert Wood Johnson Foundation, with a goal to connect directly with rural African Americans in Western North Carolina and with the organizations and institutions that are significant in their lives in order to deconstruct and combat the ways that racism has contributed to the myriad health challenges they face. I hope you will join me in welcoming them to talk to us today, and thank them very much for being part of this series.
Good afternoon, everyone. It is indeed our pleasure to join you today for this presentation. And thank you for joining us as we talk about including the invisible: race, place, and faith in Western North Carolina. And so first, we've already been introduced a bit, but we'd like to introduce ourselves through our slides as well. We are a team of 3 that have been together for quite some time, and it's amazing how we all really intersected. But as we welcome you, we would like to bring you on the road trip that we've been on. You saw a slide that just flashed by that had a semblance of the road less traveled right now, because initially in our research efforts, we were making trips out into the counties, and we really enjoyed those trips, especially Jill. She was the Uber person on steroids because she really loves to drive, and we appreciate her driving for us. But with that said, we would like to tell you a little bit more about our team and how we intersect. And so you got a brief overview about where we are, but we would like to also let you know where we're going to go throughout this process. So we're going to give you a little bit of our background, then we'll talk about the research, and also we'll talk about some of the outcomes that we have come up with. And so as you see, we have that beautiful triangle, and the triangle really intersects all of us in the way that we have come together. Jill actually used to be a board member on the ABIPA board years ago. And then when Ameena moved to town to work for UNC Asheville, she really wanted to get involved in community work. And so we started doing work in the Shiloh community and with our churches. And so it was amazing when this opportunity came about that we were all able to align, because Jill and Ameena have also worked together on MPH program. And so you will see here that we have our families, because all of us are family women, and they are an integral part of the reason that we do what we do to ensure that our community is the best place to live. Next slide. And so we would like to talk about us as a team. But after that, we also would love for you to know about our mentors. And so our mentors have been afforded to us through this fellowship project so that we can have support along the way. And so first we have Ms. Ann Miller Woodford, who is the founder of One Dozen Who Cares. We have Mindy Fullilove, who is a professor of urban policy and health at the New School. and then Ms. Wisdom Powell, who is the Director of Health Disparities Institute in UConn Health, and then Zinzi Bailey, who is a social epidemiologist, and then Kimberly Hunter, who is a realtor and a business developer here in Western North Carolina. So as you can see, we have a power-packed really slate of mentors that have been really supportive in making sure that we think outside of the box while also utilizing promising practices and structures that have already been put in place for productive research.
Thank you, Joanna. Thank you all for joining us today. I'm Ameena Batada, and I have to say this is a little bit different than we're used to. Usually we have the opportunity to see who is in the room or on the call with us, and we can't see you right now. So bear with us, and thanks for joining. We do have a question though, so we love interactivity, and so we're going to use our interactivity tools the best we can using Zoom, and we have a question for you, and Jacqueline's going to help us. It'll be in the form of a poll that'll pop up to you. Maybe you already see it, and it is a question that we often ask when we are working in Western North Carolina, and it is part of one of our research methods strategies as well. And the question is, what do you like most about living in Western North Carolina? And you can see because we had to make it a poll, we put in some answers, but if you like the mountains the most, the food the most, the people the most, or the culture the most, go ahead and give your vote. And if there's something else that we haven't captured in this short list, you can choose other, so that you can at least acknowledge that there are other parts of Western North Carolina that you find that you appreciate. Okay, and let's just take about 10 or 15 more seconds so that, Jacqueline, you can get as many votes in there as possible. Okay, and let's see what we've got here. So the red line indicates the most frequently responded answer, and that is the mountains. So it seems like a lot of people have been pulled by the mountains or have appreciated the mountains. People and culture are important, and food, interesting. We don't see as many people who've been drawn to Western North Carolina for the food. I will say my father loves to come visit because he likes the boiled peanuts, but that's probably less of a draw than coming to see the people, I think. Great. Well, thank you all for participating. That's fun. So here we are in Western North Carolina. This map represents a 16-county region, actually regions 1 and 2 according to the County Health Department distinctions, and this really represents what the region is that we are working in and with. Primarily counties around Buncombe and west of here, and we'll talk more about where we've been a little bit later, but just to give you a sense of our work and where it is located. And then to give you a sense of the background a little bit more in terms of us and our team, Joanna mentioned that I had started out working with them in 2011. And over the years of working with ABIPA, Joanna's organization, we developed a proposal and an initiative called PRAISE, which is a church-based interdenominational initiative that really supports churches in their journeys and efforts to promote and support the health of their congregation members. And we modeled it after an evidence-based program called Zone Health, which some of you may know. And through this program, churches can work toward meeting milestones or achievements throughout the year, and then at the end of the year they receive awards based on the milestones they've achieved, and those are framed as sort of medal awards, so bronze, gold, bronze, silver, and gold, and then honorable mention. And then attached to those awards are monetary prizes that we were able to fund through sponsorships and the Mission Community Investments Grants Program while we had Mission Health. And so here you see some images from some of the programming around the perimeter, and at the center top, you can see one of our award ceremonies at UNC Asheville, and one of the churches and their representatives there, which is always a great way to celebrate, is to get together and have some healthy food. So that program or initiative has been in place for 6 years now, and we're currently looking at the next iteration. And knowing just how important that the initiative has been, both in the lives of the people who've participated and in community health here in Asheville, we really were looking for ways to expand this kind of work into the more rural areas of Western North Carolina, recognizing really that as Lincoln and Mamiya state in their book about the Black church, that Black churches became the first institutions to carry the hopes and dreams of an outcast people. If they were not always heroic institutions, they at least contributed to the survival of their people in the most extreme and violent circumstances. So, as we're starting to consider how is it that racism plays a role in the health and well-being of African Americans, and what are the ways that the populations have persisted over the years, the church, in particular the Black church, has been a safe haven and a supporter and a contributor to the health of African Americans in the South, and including in Western North Carolina. And so we were very interested in how can we help churches to continue that role and be well resourced in doing that. And when we were out in Transylvania County recently, one of the community members who we interacted with, who's an elder in the Brevard area, Edith Darity, there was a poster by her, and you can see that in the bottom left quote of hers that said, "The greatest freedom we feel is when we worship." And so as we think about this project, and the background for it, I think it's really important to recognize the intersections. Not only are we looking at race and health, but we're really interested in race, racism, and rurality, as well as faith in this sort of approach that we're taking. So just to give you some background about some of these aspects, I want to start with this quote that's by a community leader who's a member of our community advisory board. And she said to us very early on in our process that the far west of North Carolina, where she's from, is 97% white. White people don't need to think about us. And that really struck us. Because oftentimes, we don't necessarily put our data into perspective like that, and she really helped us to do that. I think as we continued to learn and read and talk with people, the theme of invisibility kept coming up again and again. And this feeling that when you are a very small proportion of the population, other people don't necessarily need to think of you. You're almost invisible. And this theme is critical for the allocation of resources and for people being able to recognize what it means to communicate across difference and to provide support to individuals based on their experience and perceptions. You may know that in Western North Carolina, the percentage of the population that is Black or African American varies, and this chart gives you a bit of a sense of that, with Rutherford County, south of us, having the highest proportion of the population that's African American at about 10.1%, to Graham County, which has about 0.2% of its population that is African American. And overall, about 4% of the population in Western North Carolina is African American. And I should make a note that, we'll be using African American and Black fairly interchangeably in this presentation, although we recognize that they do have different meanings generally. When we talk about Black populations, we may be talking about African Americans, but also populations that would identify in other ways, such as recent immigrant populations from various places. And so we try the best we can to use the data source, how they've described the population when we talk about it, but otherwise we really are focused on African American experience because of the historic perspective of our research as well. So a little bit more about why we're doing what we're doing. Well, I've talked a little about the previous experiences that we've had with churches, and we know from the Western North Carolina Health Network that rural African Americans are not adequately represented in the regional community health assessment. You may know about the community health assessment is an effort to learn more about the health outcomes and health behaviors of people living in a certain area. And in Western North Carolina, we're very fortunate that we've been able to have a 16-county region actually where the community health assessment is conducted. And nonprofit hospitals have in the past been required to provide funding for these community health assessments, which take place every 3 years, and so the Western North Carolina Community Health Assessment is overseen by the Western North Carolina Health Network that provides the funds to an external group to conduct the research, the surveys, and then they are able to help do the analyses and work with the public health departments in each county to support the prioritization. But what they found is that despite the fact that they've attempted to oversample African Americans in the 16-county region, that there hasn't been enough of a sample size to do as much analyses as they would like to do. And so what does that mean? It means that oftentimes the priorities that the county puts forward on, on which to work for their local health efforts may or may not include, and oftentimes don't, African Americans. And so this is another example of how African Americans sort of symbolically and really, literally can be considered invisible in the health promotion planning of communities in these counties. And we also recognize that there's a need for additional research to explore race, racism, place, and faith. There's some additional research, and we'll talk a little about that, but this is a relatively under explored area. If we want to advance health equity, we need to think about these topics and determinants in an intersectional way. And so even though we have interest in rural health, it's not totally clear how race matters to all stakeholders when you take both into account. So this should come as probably no surprise given your interest in being here with us, but part of what drives our work are the Black-white disparities in health and the rise in what we see as the gap as well. And the risk factors are also increasing as well. Here in North Carolina, the Western North Carolina Health Network has been able to gather some data that is useful. Buncombe County actually has the highest percentage in terms of the survey, or the highest number, sorry, of respondents in terms of the survey. But when you're looking at the county, the Western North Carolina Health Network reports that African Americans are 79% more likely to have prediabetes than the white population, and 87% more likely to experience high blood pressure. So those are just two outcomes that indicate the disparity along the lines of race in Western North Carolina. And then if you look at the contribution of income as well, this chart shows that African Americans who are of middle income in Western North Carolina are almost 6 times as likely to experience high blood pressure compared to low income white populations, and then 2.6 times as likely to experience diabetes, and 1.6 times, or 60% more likely to experience obesity. So there is a contributing factor of income along with race in this case. So, so there's, as I mentioned, a small and growing amount of research on racism and health. Primarily, though, the research is focused on personally mediated discrimination. So that means discrimination between people and perceptions of that kind of that kind of racism. There's been less research on structural racism and health. And when we're talking about structural racism, Jill will go into it in more detail a little later, but we're talking about the interlocking systems and cultural perceptions that work together to create influences on people's health and well-being. And we know from some research that segregation has been shown to be a risk factor for cardiovascular disease as well as other health conditions among African Americans. And so if we think about the rural-urban differences, that's part of what we're trying to understand with our research as well, is how does race and racism operate in rural settings. We like to show this diagram because I think it illustrates just how complex all of this can be. This comes from a seminal article on racism and health by David Williams and Muhammad. And so they have really laid out, as you can see here, causes and how those relate to social status pathways that are closer or proximal, and the responses that then lead to health and either good or poor health outcomes, and as they relate to racism. And so when we started doing this research, our mentors were asking us for a framework, what's the framework you're using? And I think we kind of were like, well, this is a framework, and just it illustrates just how challenging it is to really try to isolate variables or determinants of health when you think about that relationship between racism and health. And so if you take this, which has to do with racism, and then you think, how does this operate in a rural setting, then you've got an additional layer to consider. And so thinking about the rural dimension, we know that there are rural and urban disparities in heart disease and other health outcomes, as well as risk factors from the research. And we know that there's some research that talks about the racial disparities in rural areas, but it's very limited to date. And there is actually a call for research to understand the intersections of rurality and race and racism. In Western North Carolina, we thought you might be interested, again, from the Health Network, and this is just for people living in the more rural areas, regardless of race, that people living in rural areas are 19% more likely to experience high blood pressure, 20% more likely to experience high cholesterol, and 33% more likely to be obese, or considered in the category that is obese. And so we know that then if there are also health issues and disparities associated with rural residents, we then are, continue this question of, okay, how do then race and rurality play a role? And then as I started out talking about the other aspect of our research, which kind of fits with the first two aspects, but is also kind of an independent question for us, is how does faith play a role? As mentioned earlier, faith communities and partners influence the health and well-being in rural areas, and what we've been learning is that it can be positive and it can be negative as well, and that as they said in the report on achieving rural health equity and well-being, churches have much to contribute in reducing disparities. And we also have been reading about the potential for community-based participatory action research and working with churches, African American churches, because they create an empowering environment and are able to address the myriad health issues that the members and the community confront. And so that kind of brings us to the doorstep of our research. And so, when we were getting ready for the presentation, Dana said, "Oh, we want you to talk about what you're doing." And we said, "But we're not done." And she said, "That's okay." So here we are presenting some information about what our research has started looking at and doing, and a little bit about the preliminary findings. And we hope that we'll have a chance to communicate to you at some point in about a year when we have all of the results, looking good. But in the meantime, we encourage you to take a look at what we have, and also we welcome your input at any point in this process as well. So with that, I'm going to mute myself and turn it over to Jill. And Jill, I'll advance the slides when you let.
Thank you. Great. I'm Jill Fromewick, and I'm also so excited to be here with all of you. Yes, as Ameena said, this venue might be different, but it's nice. I feel like I'm with people, which is always exciting. So the traditional definition of research is kind of a systematic investigation to establish facts and reach new conclusions. And I think my colleagues would be in agreement with me that that's not our ultimate goal. As we'll discuss a little bit further, our research really aims to make change, to contribute, as we'll show, to a culture of health. And we believe that our process is sometimes and sometimes even more important than the product. I do like the word systematic, however, when we are talking about research, and I think it's important to remember that. When I teach a program evaluation class, I often say, we're doing evaluation and research all the time. So I make my son dinner, and he says, ew, yuck, and I take in that information and I might make changes. Maybe next time I won't burn it, for example. We'll see. That's to be determined. But research is really systematic. We're collecting information from multiple people. We have interview guides, even if they might be semi-structured. Next slide, please. So our funder, Robert Wood Johnson Foundation, has really been a leader in racial equity work. They fund a lot of incredible work, and they put out many products. So this framework of the culture of health that I show you on the left is really synthesizes their national agenda. And as you can see in the middle is not only improved population health, but improved equity or equity. So at its center, really, that's what our purpose is. So we always, and I'll say this probably multiple times, really want to keep the end in mind. And we're always, I think every meeting we have, which is weekly, we are talking about to what end? Why are we doing this work? Can we shift anything to make sure that our work is really not only as one of our one of the community residents said at our meetings, admiring the problem. And we're always asking those questions of ourselves. So we're really heeding the call of previous research. Rachel Hardiman and Katie Casamano are some of our research rock stars who we love from University of Minnesota. And they highlight the power of research to contribute to lifting the barriers of racism. They say, as clinicians and researchers, we wield power, privilege, and responsibility for dismantling structural racism piece by piece. So I think words like theirs are really our guide as we move forward. We also aim to center the experiences of Black and African American residents. And so again, not about just looking at the problem. And we'll say a little bit more about how we're hoping to do this. Just quickly, this framework is also focusing on fostering cross-sector collaboration, which we're always thinking about, making health a shared value, strengthening the integration of health services and systems, and creating healthier, more equitable communities. So we're always keeping that in mind as we go about our work. Next slide, please. So as Ameena has already shared, it's important to know that many studies look at disparities in health, and this is less so now, but still true, without saying why, leaving many to believe or implying, and this is especially in medical journals, that those differences are related to some biological concept of race, which we know is not true. What Kamara Jones, professor and brilliant leader and researcher, says is that race is a proxy for racism. So racial disparities are not due to biology, but racism, as Ameena has shared. So that said, even most research on racism and health is focused, again, as Ameena shared already, on interpersonal racism and discrimination as stressors. So Zinzi Bailey, who's one of our mentors, so lucky to call her a mentor, and other colleagues call for research on structural racism and health, which would really pinpoint specific areas of action. So Bailey names several pathways by which structural racism is linked to health. Residential, which are all, I would say, especially highlighted right now, even though these have not changed. A lot more people now know that this exists. So discriminatory incarceration, residential segregation, healthcare quality and access, which is true throughout our country and here in Asheville and in Western North Carolina. So what we want to do is generate a framework for understanding how structural racism may be linked to health in rural regions. So a couple of our working definitions, and we could have put so many here, but structural racism. So we're really thinking about not only those day-to-day, thinking about one person's discriminatory actions, but really it involves interconnected institutions whose linkages are historically rooted, which is such an important piece of this, and culturally reinforced. We're talking here about the totality of ways in which societies foster racial discrimination through mutually reinforcing inequitable systems that in turn reinforce discriminatory beliefs, values, and very importantly, distribution of resources, which affect adverse health outcomes. So we're seeing this here with our intersecting pandemics. I think this is becoming very clear that racial disparities in health is just becoming so clear to us with COVID, but it is true for really most every health outcome. We define health more broadly than physical health, so physical, mental, emotional, and social behaviors and well-being. So a lot of what we talk about with our work is mental health. Next slide, please. So our primary research question is we really wanted to talk about how race, place, and faith intersect. And so our main research question is, what is the role of the church in influencing the impact of structural racism on health among African Americans in rural Western North Carolina? So we're looking at structural racism and health, and also how the church mediates or influences that. Next slide, please. So with that, we also have specific research questions. Number one, what is the relationship between race, which is, we know is a proxy for racism, and health in rural Western North Carolina? How does structural racism influence health among African Americans in rural Western North Carolina? And in what ways do churches influence health and the impact of racism on health? So this is guiding our work. Next slide, please. So where we've been, as Joanna said, we have logged almost 1,000 miles, mostly with me driving because I really like to drive. So luckily my colleagues do not, so it works out really wonderfully. And we have gotten to know each other very, very, very well on these road trips. So out of the 16 county region, we have held conversations and broken bread. Food is very, very important to all of our conversations. We made sure that there was money in our budget to take everybody out to lunch. Very important to have conversations over food. Broken bread in 5 counties displayed with the red dots. And also hoping to embark, though it might be virtually, to other counties, Yancey and Rutherford. We've ridden through small downtown trick-or-treating. We've attended regional conferences. We've taken walking tours. There's a wonderful one in Brevard. We've encountered roadblocks because the streets were closed due to greening of the mountain. And all of us vegetarians have been to several steakhouses. Next slide, please. As I said, it's very important for all of us and very, very important for the grant and Robert Wood Johnson Foundation. A large part of this grant is professional development, and they really have strongly encouraged us. I think all of us came in with this lens to begin with, but I think the work that we've been able to do with Robert Wood Johnson Foundation and the training has really reinforced this and helped us gain more skills in doing this, to keep the end in mind, the so what. So we very intentionally ask, what are the benefits? What do we hope are the benefits for this research? And we'll talk more about the accountability we have to that. So thinking about keeping the end in mind, our hope is that for African American residents of Western North Carolina, for our community advisory board who's guiding this work, they have said that they want these things: increased visibility, participation in the community advisory board, increased access to programming, better health quality, improved social and health conditions, more resources, and increased community connections. So that's our hope for the end goal. So what do we have to do? Who are the audiences of our findings in order to get there? So very intentionally, we've named churches, public health departments and hospitals, MAHEC, where I work, and other healthcare systems, community organizations, and funding partners. So we have sat down with representatives of all of these groups and continue to do so to say, what information do you need to be able to serve African American residents, all of your constituents, all of your patients better? And so they tell us, and so we say, how would you like to receive this information? So the hope is that we're tailoring information towards the audiences that really matter from the beginning. Next slide, please. So another part of this grant and this work is that we're really focused on community-based participatory research. And there's a wide range of what that looks like. In general, community participatory research is a partnership approach to research that community members, community residents, researchers, and others really partner in the process by contributing expertise and sharing in decision-making and ownership. And so the research is not kind of done in a silo just by researchers aiming with a top-down approach, but really getting input from the beginning and really sharing some decision-making. In this, our heart, we'll say, and Joanna will talk about this more, is our Community Advisory Board. We hope to support community priorities. We're collaborating with community partners on advocacy, and we're also employing community members as researchers. That's really important to the work. Next slide, please. Getting to our study design, just walking through briefly our plan. It's an observational descriptive study design. That means that we're not implementing any experimental elements. This is not a randomized control trial. We're gaining a snapshot at this point in time through interviews and focus groups, as I'll share a little more about, but we also have retrospective components where we're looking historically. One of our mentors, Dr. Mindy Fullilove, brought our attention to a method she's used, situation analysis, where researchers examine and define a situation or a complex state of affairs in the context of larger societal, political, and economic systems. Excuse me. So it implores us to look at both the interior and exterior of a situation, which we felt was very relevant, given the complexities of structural racism's impact on health. Also, this is a mixed method study. We're talking qualitative and quantitative and multi-phase. Next slide, please. The methods that we're using are secondary data analysis, historical, social, and political analysis, in-depth interviews, and focus groups. Talking about the secondary data analysis, first I want to give a shout out to Dr. Sherry Denslow, my colleague at MAHEC, who's a statistician, epidemiologist, who's really helping us really unravel and tease out some of these very complex associations. So we're looking right now at differences in North Carolina mortality by race and rural status. We're looking at individual level vital statistics, mortality data for all 100 counties in North Carolina as of right now, 2014 to 2018. And each individual death record includes information. So this is a great data set for you researchers out there. I know that there's some of you. Next slide, please. So here we looked at both race and place-based differences in premature death, following what some of our colleagues have done. We've also done this analysis for other outcomes. But premature death is measured by years of potential life lost before 75 per 100,000 people. And so initially we had conducted our analysis using all-cause mortality, but we wanted to complement some of the work that, as I talked about before, Dr. Hardeman and Dr. Casamano had done, and kind of advocate for using premature death. So you're looking here at 2018 data. You can see the differences in years of potential life lost by race and rural, urban. We know that simplifying rural status as dichotomous, rural, urban, is a major simplification. There's a lot of nuance there, but we're planning on doing some additional analyses to look at more finer grained characterizations. Notable differences in African American and white years of potential life loss in both rural and urban regions. And you can also see that overall, for both white and Black residents, there's more potential life loss in rural regions. So I think this really kind of shows how both are working at play here. Next slide, please. We also did look at differences in mortality rates by race and rurality. We're looking at data within different age groups. So again, for those statisticians out there, we did not age adjust any data. And here you could see a line graph. I know this might be a little bit hard to read, but it shows mortality group for different age groups at the bottom between races and urban rural status. So overall, Black residents have higher death rates, rural have higher death rates, And we tease this out a little bit in the next slide. So on the upper left, you can see that for most age groups, African-American rural residents have the highest set of mortality rates, then urban residents, then African-American urban residents, then white rural residents, then white urban residents. And I am going to leave it with Ameena, pass the baton to Ameena Batada to talk about the exciting words behind the numbers.
Great, thanks, Jill. Yes, so what Jill has described is really addressing that first research aim that she shared earlier, where we were interested in differences in outcomes by race, which in this case suggests that there are some things systematically potentially happening. And then we're also interested in racism and how racism has played a role in the lives of African Americans living in rural Western North Carolina. And so we took a few different approaches to learning about this information. And the first one that I'll share is this historical, social, and political analysis, which speaks to that situation analysis that Mindy Full-of-Love and colleagues have introduced. And what we set out to do was to understand a little bit more about the African American population and churches over time. We also have been reviewing documents, reviewing documents that have been written and created here in Western North Carolina, and trying to understand better some aspects such as land ownership and economic ties, as well as independently economic stability, access to resources, and policies, specifically discriminatory policies. And we're also conducting a, one of the pop-ups. So we're also conducting a content analysis that is looking at the frequency and nature of instances of racism and their relationship to health behaviors and outcomes in oral histories. And so we'd like to share a little bit of the information that we're putting together. And here I would like to make sure that I recognize the many research assistants that have worked with us over the course of the last year and a half, including Kaylee Hackett, Amanda Morgan, Kadaya Ross, Deja Jefferson, Desire Brown, William Walden, Jake Hall, and a couple of others who've kind of stepped in here and there. And these are all UNC Asheville students who have worked with us to help us to delve into the data and the information a little bit, and to put together some of this information. So here you can see that we looked at the it's going on its own. We looked at the population of the Western North Carolina, the various counties, and what percentage of that population is African American. And what we found, first of all, that was very interesting was we were able to get data as far back as 1790, but that we didn't have enough information as we would like to include that information in the chart. So we here. And if you look at the bottom of the chart, you can see the categories that were used to describe the African American population, and those vary from 1850, where the census, which is a source, the U.S. Census, which is the source for these data, described a category for slaves. And then by 1860, they had separated out population of free colored, and that was black and mulatto in parentheses. And then you can see they moved to just colored. They had percentage Negro, and then they went to non-white, which is why we think we may see an increase in some of the counties, because it seems to be a larger catch or category than Negro. And then they moved to Black, and then Black or African American over time. And we thought this was pretty illustrative of just the perceptions and the racism itself and how we categorize groupings. And then, as you can see in Western North Carolina, in most counties, the percentage of the population that's African American has been declining over time. And the population has gone just in 1920 from 10% down to 4%, as Jill shared earlier. So we're really seeing that invisibility play a role in a way now potentially that is different than how it was played, how it played a role in previous years and decades. Here you can see a chart that we've been working on looking at the percent of the overall agriculture producers who are African American or Black in Western North Carolina. And this is only from 1987 to 2017 because those are the years that we have agricultural census data. And it looks at first, oh, it's all over the place because we don't have data from every county for every year. But what is interesting, I think, to note is one, that the percentage of the agricultural producers who are Black and African American has not changed a whole lot. It's usually under 2% for most counties. And if you think about the population we were just talking about, if we went from 10% in 1920 down to 4% even today, that suggests that as a proportion of the population overall, it is not representative, and that Black and African American farmers are not owning or producers or owners of farms at the same rate as they are members of the community. And so we're going to be doing some additional exploration in terms of agriculture, but this is a very significant issue right now in terms of land ownership and racial status. And then I mentioned that we are working on a content analysis of oral histories. Western North Carolina University has a fairly nice collection of oral histories that have been conducted with African Americans in the Western North Carolina area, and these are all available to anybody who'd like to listen to them. And so a team of undergraduate researchers has been coding the oral histories, which means that they've been listening to and reading the transcripts from the interviews and then assigning codes to specific themes that have come up and that we have identified in the interviews. And so we've coded for information around life experiences and racism and the levels and types of racism that they are talking about, as well as health behaviors and outcomes and references to the church. And currently we're in the process of analyzing the data. The initial coding has been completed. We're cleaning the data, and now pairs of students are going in and identifying the themes that have come up within each of these categories or codes. And I just brought a couple of quotes that I thought were interesting. One is, well, it's not like it is now. We couldn't go in front of a cafe and order out food. We had to go around to the back and go in. So we hear a lot of stories of segregation and segregated spaces that come up again and again. This seems to be a theme that's really critical to the people who were interviewed in the oral histories and in other aspects of our research as well. And then another quote is that I think is illustrative of what we've been hearing is this one. We had more Black businesses then than we do now. We had a Black newspaper, we had Black grocery stores, we had Black shoe shops, and Black cleaners and Black clothing stores. And something that we are seeing in the information that people have been sharing with us is really this sense of community that has been lost in a lot of places. One particularly because of the loss of African Americans from the area. And so what that implication might be for the health and well-being. So maybe not personally mediated racism like maybe the first one, or institutionalized racism potentially, but also but also the protective factors associated with being in community and having that economic stability as well. We're also in the midst of conducting our own interviews. So we've been able to conduct interviews to look into questions that we are interested in that, that were not asked in the oral histories. And so we're hoping to complete about 20 to 30 of these. We're using what's called a snowball sampling strategy, which involves asking people to refer other people to be interviewed. We started with our community advisory board and others. And these interviews are semi-structured. They last about 90 minutes, and they involve questions about the people's personal and community health experiences. We ask that question, what do you like most about living in Western North Carolina? You know, and what's a challenge? We ask them that too. We ask them about their perceptions of the role of racism in health and in their community. We also ask them about the church and if the church plays a role. And because we're interested in not only in gleaning information, you know, about the topics, but also in understanding how people want to see a change or a difference made, we're also asking people about their ideas for programs and policies. And we're in the midst of coding right now, and we're planning to use a flexible coding strategy using a software called RQDA. And here are a couple of folks in the midst of an online interview, because we have been moving to some online platforms for the interviews. You see Dawn Colbert on the left, who is one of our team members. She's the research coordinator who's located west of us, and Texana, and Ann Miller-Woodford, who is out in Andrews, and so you can see them talking with us. To date, we've completed about half of our minimum interview total, and we have, as I mentioned, started to develop our coding structure, which includes a multi-step process of going through the existing interviews and deciding on codes, much like the oral history coding, but using more of an inductive approach rather than a sort of a deductive approach to looking at the data. And then we currently have planned focus groups, which we will utilize as an approach to further explore some of the themes that have emerged from the in-depth interviews. And so we'll identify groups of church members and residents with the help and guidance of our community advisory board, and plan to conduct somewhere between 8 and 12 focus groups. This is a little challenging because the in-person experience really makes a difference in focus groups, and given where we are now, this has been a question on our minds, and we're trying to figure out if we'll be doing these by Zoom, like we're having this call, or if we'll do some by phone or use some other strategy. And so we'll again reflect some of the same topics that we've been exploring already, but also use these opportunities to delve deeper than we have in the interviews and archival and secondary data analyses. And similar approach in terms of coding and looking at responses and themes using a qualitative data analysis software. For those of you who are intrigued by the research, and you may be thinking about some of the limitations already, despite the influence of structural racism on health in detail, I think this is a challenging area of research because you know, there's so many factors, as we know, looking at that framework from Williams and Muhammad. And so the limitations that we bring include that limitation, as well as the fact that we're conducting our research within the context of communities in a rural region, but we're not surveying or talking with everybody in the rural region. And so recognizing the variation and lack of full representativeness or representation is important. We also recognize that the people who we recruit may have experiences and may have access to better health and better health care, and then maybe the people who are not necessarily involved in the interviews and focus groups. I think Jill talked a little about this, but a secondary data set also has its own limitations in terms of what variables are collected through the vital data program through the State Center for Health Statistics as well. So I'm going to transition over now to Joanna, who's going to tell you more about our CAB and some of our next steps and work that she and others have been doing specifically on the ground, as they say. Thanks, Joanna. Just let me know about advancing the slides.
Yes, and so again, you know, public health world is full of acronyms, and so what the CAB is our Community Advisory Board, and so our Community Advisory Board has really been a swath of individuals that are in the outer counties that we've been able to connect with through what we would like to say, which are warm leads or warm handoffs through our work, because all of us, as you know, are based in Buncombe County. But again, this work is more regional. So this has been very helpful to us to be able to have people that are in Buncombe that actually connected us to the counties. And one of those are our mentors, because before we started our work, Ameena actually had connected with Ann Woodford around her work with One Dozen Who Cares. And so again, that was a warm handoff into the community, because we were able to reach out to her, who in turn was able to also refer us to a couple of people and let them know that Joanna or Ameena will be calling you. And then this is what the work looks like that we're going to propel forward together. And so really, this has really been a work of the heart. Well, we started and made sure that we really had guidance on the designing and implementation and communicating the project. And so even the name of the project really evolved from what our original research question itself was, and or the name of our project. Next slide. And so here you can see our CAB at work. We were able to go out to the Jackson Library where we all met and really were able to get a lot of work done as individuals and as a group. And I saw that one of the questions in the chat actually asked how did COVID-19 really impact our work. A part of that is that we haven't been able to convene in the way that we have normally, but we have been able to utilize Zoom as a platform to gather. But again, because of technology and bandwidth and things of that sort that have become barriers, some of our CAB members have not been able to join on a regular basis when we've had these meetings in the interim. However, we have been able to get a whole lot of meaningful work done. And so that has allowed us really to propel our work forward, even amidst having to exist in the pandemic. Next slide. And so again, here you see our CAB members on display. We are a very intimate group, you know, and some of them knew each other before and many of them did not. And so this really has allowed us to expand not only relationship when it comes to research, but also community, in that resources that each of them may bring to the table have really widened the scope of work that they're able to do as individuals as well as organizations. Next slide. And so, look, we can go ahead through that next slide because you see me on display as we are there working through some of our mapping and questions that really allowed us to think about how we're going to take action. And so that really takes us into what is action. And one of the questions that we also received in planning for this presentation was who is ABIPA? And so I believe that is a part of the next part that we'll take you through. So also, I've skipped this part, I apologize, but we're also having the potential of expanding the work of the CAB. And a part of that is really seeing how we can have community-based research leaders that are embedded in the community. And so this is a part of the work that the CAB has been afforded as an emerging opportunity. And so we have a potential partnership with WNC Healthy Network and on the 2021 Community Health Assessment. Also, we're working with supporting rural organizations and contributing to departments of public health all at the same time while integrating the expertise of those that are on the ground in the form of our CAB members. And so again, this is a very unique opportunity because I know that you all discussed it before, that sometimes when it comes to the data that we have, there are gaps. And this is a way to really fill in those gaps utilizing the people that are being surveyed in a way that oversampling may be able to be implemented in such a way that we can really hear the voice of those individuals who really feel like they have not been seen or heard. And so we're really proud of this as an opportunity evolving out of our work, because we really didn't want this to be a grant that for 3 years we were collecting information or being extractive, but how do we also support having systems in place where community can continue to support community and inform community investments. Next slide. Now to who is ABIPA. Really, we've talked, everyone knows who MAHEC is, everyone knows who UNC Asheville is, but we have had the question, what is ABIPA? So ABIPA is the Asheville Buncombe Institute of Parity Achievement. And so we really look at health in a holistic manner, where we really feel like we are the community connection to health. We focus on African Americans as a focus group because we know in our region and historically and presently that these populations have been marginalized and it has negatively impacted health outcomes, as we have seen in result of the pandemic. We knew that health disparities were existent before the pandemic hit, but now there has been a microscope or a light that has been shed upon it. And so really ABIPA has been in place since 2004, and we're celebrating our 16th anniversary, or our Sweet 16, I would like to say. But with that said, when I was reflecting on this presentation, ABIPA was created by a retired Army doc. And so that's really prevalent to the scope of the work of OLLI. And then also one of our biggest advocates and biggest parts of ABIPA is Kathy Avery RN, who is now also retired, and she has done the most of her work and the most impactful work even in her retirement years, where she is now more busy than ever. And so this, again, in the way that I normally do, is really a call to action for those that are on the webinar at this time to really think about how we can utilize our passions and our purpose to really propel the work forward that is important to us, even amongst a pandemic. And so you'll see how we have really shifted as ABIPA, the organization, because we really focus on preventative health education, advocacy, and connecting people to resources. And so as the pandemic hit, I always like to joke that I have my best epiphanies while I drive. And so I was on my way to pick up my daughter from college because everything was shutting down. And I knew that funding opportunities were about to be afforded the community just as a response mechanism. And something in my gut said, you know, we're going to need masks and sanitation supplies for the African American community that is under-resourced. And so that's what I put in for at the beginning of the pandemic, before masks were required or before we knew that people would be hoarding things on the shelves and things would be priced out of people's way of just being able to get things like Lysol and sanitizer, where you used to be able to get it for $1, but now it's almost $5, $7 just to get it at places like Ingles and things of that sort. So at the beginning of our journey, we're just so happy to have been joined from an investment standpoint from the Community Foundation of Western North Carolina. They invested $10,000 in our work to make sure that we were able to supply 1,000 masks and sanitation care bags, which are pictured in the pictures to follow. And so that's where we started. But what's amazing about this work is that the investment that was initially made afforded us to be able to do 1,000 masks, but because of other in-kind donations and community support, we were able to leverage that up to having over 20,000 masks that we were able to distribute in Asheville, Buncombe County, and in surrounding areas. And that was, again, say, Joanna, how is this relevant? This is relevant because of our CAB. We were able to spread out into Jackson County and Cherokee and Swain and Rutherford and all of those in between because of our contacts that we had made through our CAB. So as you can see here, you see again one of our CAB members, Don Colbert, and also Pastor Lee, who again have made sure that we were able to connect to the churches, able to connect to communities like Texana. And then we were able to really make a more in-depth contact into the community in real time, that had we not been doing this research ahead of time, it would have been a little harder for us to expand in that way. Again, we've talked about the small populations of African American in the Western counties, but this allowed us to again address the needs of individuals who have not been seen historically. And so again, we just thank all of our partners like United Way that you see posted here, who gave us 7,000 masks towards that 10,000 masks. We also like to thank Southside Rising, who is a community group right here in Asheville, who gifted us with 1,000 masks. And then the Poor People's Campaign came along, and they actually did a drive-by drive where people dropped off the contents that went into our care bags, which you see at the top left side of your screen, which you can see are pretty hefty. And I would like to tell people that I would go on a bear hunt every morning looking for things that I knew that people didn't either have the money or the resources or the transportation to get out at 7 o'clock in the morning to pick up 2 things of Lysol or 2 things of paper towels. And so this agility afforded us to be able to impact over 250 people with care bags that were valued at over $50 a piece. Because again, we know that there's price gouging on things, but we didn't want people to feel like they couldn't clean their homes in an emergency situation, and or to make sure when they're going in and out of their homes that they feel safe when they return, and also that are really remediating the effects of the pandemic. And so I really feel like even though there are so many things systemically that need to be addressed when it comes to structural racism and all of the things that we are really being impeded upon us at this time, this was something small that we knew that we could do that could really make a big impact at the same time. And so I just still really encourage everyone to really think about what that thing is that you can do as an individual, even on boards that you sit on, to really think in a way that is different than what you originally thought. Because even with the beginning of our mask procurement, I really made sure that I wanted to have Eagle Market Street Development, which is an African-American nonprofit here that also has Women That Sew. And so we were able to give money directly to them to make sure that not only were we infusing income or the economics into the ecosystem of the African-American community while serving the African-American community at the same time. So we were able to give that money to Eagle Market Street, which again was able to keep their ladies working. But then how do you leverage that? The example is that when we were getting in-kind donations from Dogwood Health Trust, I told them that our first initial batch of masks we procured from Eagle Market Street. And so then they started to procure Eagle Market Street's masks for our efforts, as well as putting them on the vendor list for those that were coming to them for donations. And so again, that's how you leverage that 1,000 masks that we did in originally, or the $10,000 of an investment that actually rolled over into, just from interactions with us to Eagle Market Street, $30,000 straight into Eagle Market Street and into the community at the same time. And so that's how I think that we really need to think of things that are right in front of us, and how do we make sure that there aren't barriers to ensure that money flows within the ecosystem of our total community. And so we're about to draw to the close, but with that, I know that people have more questions. And so we would love to drive you to some more ways that you can connect with us. And so a part of that is if you go to our site for our group, which is the Heart of Health WNC.wordpress.com. Again, that's the Heart of Health, Race, Place, and Faith in Rural Western North Carolina, where you can interact in real time and see updates on our project, as well as connect with us through email if you have questions or ways that you could be involved, or contacts that you may have in the outer counties that you think could really breathe some extra energy and insight into our work. And then finally, I would love to always drive you to our website for ABIPA, which is www.abipa.org, for the Asheville Buncombe Institute of Parity Achievement, where you can again also become one of those supporters that allows this grassroots operation that is very small but does mighty work, continue to do the work in innovative ways. And we know that you are supporters, even though we don't see your faces. We know that you will come alongside us if you have not in the past, that you will join the ranks of the army of advocates that we need in a time like this to ensure that not only Asheville and Buncombe County, but our neighbors in Western North Carolina are taken care of. So that's all that I have for you today.
I want to thank all of you, Ameena Batada, Jill Fromewick, and Joanna Grier-McEachin, for presenting this work that helps us see our communities in new ways and invites us to be part of an army of advocates. So thank you so much. We are a little bit over, but I believe my friend Dana Azar is going to see if we have some questions from our audience. I also want to remind people that we will be posting these links to ABIPA and the website for this project on our website and in our newsletter, and also the recording of this webinar. So look for that probably in about a week.
First of all, thank you so much. Your project was surely heartfelt, and we appreciate your sharing it with us today. There were a number of questions. One was, has HCA picked up where Mission Health left off in terms of financial support of the PRAISE program?
Well, Joanna can also speak to this. Whoever asked that question, that's a question after our own hearts, of course. Our understanding is that right now, at least my understanding, I should say, is that the Dogwood Health Trust is sort of the main vehicle that's related to the sale of Mission, but I don't know what's happening with HCA specifically. I don't know if Joanna or Jill, you know, if they're going to be establishing a community investments arm like Mission had.
That's a good, I think that was a good answer, Ameena. No, we have not heard from HCA in particular as an entity. Again, Dogwood Health Trust has, just like Ameena said, has taken over the beneficiary part of taking care of community work. And so right now, PRAISE has not been pulled into that stream because, again, one, just as soon as they were transitioning, we were met with COVID-19, and so funds really have been allocated in a different way, really making sure that those efforts are supported. But I'm really confident that because of the history that we've had with Mission Health, that HCA should be supportive, and I'm sure that Dogwood Health Trust also, as soon as the pandemic is under our belt, will probably come back on to support the work to make sure that it continues. But even with that said, the way that the initiative was formulated was that we could make sure that we were still able to give services to individuals and to congregations and build sustainability within that structure. And so we had 5 years under our belt. Year number 6 really got taken from under us. But I really believe that going together with community support and donations from community members like you, that we can continue to build a fund so that we can continually give support to our churches, because we know, to be quite frank, that they're struggling right now because of the way that they haven't been able to hold service in a way and collect tithes and offering. And so really, even though we know that health is an integral part of everyday life, we know that that has, again, been put on the back burner just because of people being in survival mode. So I hope that answers the question adequately.
Okay, thank you. So another question was some questions that just call for some clarification. Would you say your proposal is something that you would call religiously based?
Well, I will speak to that first, but I don't think that it's religiously based. I think it's spiritually informed. Can we say it that way? Because, you know, when you think about the heart of health, it can be seen in a part of being based in the church, but then it depends on what your belief system is. And that's why we really talk about the heart of health, is because there are all of these things that are really interconnected. And the way that we look at it as a ABIPA is health is holistic. So that is a part of your social, your physical, your mental, and then your financial health. So all of those things really come together. So even though we have a part of it that is embedded into the churches themselves, really it goes to the heart of the whole community.
Okay, spiritually, I like that. That's a good answer, Joanna. Also, a question, someone that's been in healthcare for 40 years who says that these disparities have been known, and what are we waiting for?
Well, look, I'll say something and I'm going to ask somebody else to jump in too. I don't think that we are waiting for anything, and I don't even think that the people that are on this call are waiting on anything. I think that the people that are in power have not built systems in a way that could equitably make sure that everyone is taken care of. And so when we come together to ensure that we are able to ensure that people have adequate health care, adequate living, a living wage in Asheville. You know, when we think about that, even in retirement, making sure that you have somewhere that you can retire without worrying about your bills. All of those things work together in an ecosystem. I go back to that word, because without one thing being in place, we really can't be successful. So when we really bring to the table the solutions that we already know work, fund them, but then not only fund them, because we know money doesn't solve everything. The structures that are built can still impede success. So Ameena, Jill, your feedback?
Sure. I would say we all agree with your question, or I would say I as well agree with your question and ask that question all the time. All of us are also involved in kind of actions, policy advocacy in other respects. And so I think part of this work is saying, okay, where to pinpoint focus that's kind of led by, again, a lot of the community health assessment data is really focused on white populations, and that's how a lot of the health departments are making their decisions. And so part of this work is to ensure that a lot of those decisions, which inform health outcomes, are also informed by Black populations and residents who live there. But we agree with you.
I think we all do. One last question. How do we clarify how race matters to the issue of health equity?
Can you say that one more time? I'm sorry. I'm trying to look for the questions as I'm.
Okay. How do we clarify or get across how much race matters to the issue of health equity?
Okay, I'll start this one off again. But I really think when you, in practical terms, it is just shown to us just from the facts of the disparities that have been highlighted through COVID-19. So race matters all the way around. And if we take care of what matters to race, we still take care of society as a whole. So, you know, I like to think about it in the way of just Asheville, Buncombe. And we know that the African-American population is just a little over 16,000. And so visually, I'm a visual person. That's like filling the Sherrill Center 3 times. And I say in my heart, if we cannot take care of the health of that amount of people, with us being a resource community, that is an issue of public health. And that matters whether it comes to race, whether it comes to gender, but specifically around race, because if we can't take care of those individuals, how do we take care of everyone else to ensure that we're living in the best county in the country? And I believe that we have enough thought leaders, we have enough progressiveness, and we have enough ingenuity to really make it happen. It's just a matter of doing it. And I think that we're in the juncture of history with all of the proclamations that have been made, whether it's around declaring racism as a public health issue, whether it's addressing reparations in a way that is ensuring that businesses are revived and that neighborhoods are revived. And so, and really defining what that means, and not just by a tagline, because taglines can get misconstrued many times. But when we come back to the heart of the matter, you know, that heart that we've been talking about, all of us want to live well, we want to love our families, and we want to be able to enjoy life. And so what does that take when we're talking about our health and supporting the health of our community?
Thank you for that. I think we're out of time, but we still, you'll have an opportunity maybe to pose your questions in another manner. Thank you so much.
Yeah, thank you. I can't imagine a better place to end than what Joanna just said. So thank you for that very much. We will post the recording on our website. If you have further questions or you feel a question you asked didn't get answered, please just email us at olli@unca.edu, and we will pass the questions along to our experts here today. So we just want to thank them again. I'm sorry you can't hear the applause that I'm sure is going all over Asheville right now. We hope you'll join us on Thursday, August 27th at 3 p.m. for our next discussion titled Criminal Justice Disparity. This session will be moderated by OLLI member Curry First and include Asheville-Buncombe County DA Todd Williams, Asheville City Manager Deborah Campbell, and Public Defender Leanne Melton. Thank you so much for joining us today, and thank you again to our wonderful panelists and for the wonderful work that you're doing in our community. Thank you.